Hey y'all, it's Chandler. I want to thank Keith and Respiratory Associates for letting me come on here and chat with you all about some subjects that maybe as RTs we don't get to participate a whole lot in or get to see a whole lot of, and something that I've always found very neat, which is hemodynamics. A couple objectives for this course. We'll review general hemodynamics as many of us learned them. We'll relate cardiogenic conditions to hemodynamics. We'll relate non-cardiogenic conditions to hemodynamics. We'll look at ARDS and congestive heart failure, and we'll look at these as they relate to or how they may manifest in our hemodynamic values. Excuse me. So general overview, it's important to understand that blood, it just keeps going, right? And if blood doesn't keep going, we have much bigger problems at hand other than measuring hemodynamic values. I've always said that understanding blood flow as it relates to regular anatomy and physiology can help anyone to really create an understanding of how certain hemodynamics are impacted by certain diseases as we follow the flow of blood through the heart and even other places in the body. So I always said, what do we want? We want homeostasis, and we want it for, generally for forever, I guess, in the perfect world. But this is not always the case, and we know that a disruption in the flow of blood anywhere in the body creates a cascade effect that ultimately down the road will impact the whole of the body. So to follow the flow of blood through the heart regularly, we'll look at the greater vessels, which dump into the right atrium, which moves through our tricuspid valve, through our right ventricle, out of the heart, through the pulmonary semilunar valve, through our pulmonary artery, to our lungs, to the pulmonary veins, to the left atrium, through the bicuspid or mitral valve, as some may know, through the left ventricle, through the aortic semilunar valve, the aorta, arteries, arterioles, met arterioles, capillaries, post-capillaries, venous veins, and then through the heart again. So we understand the pressures behind these certain structures. We understand how these certain structures work, or how they're supposed to work, rather. Then we can kind of start to guesstimate what may happen if a portion of it starts to fail, right? And it's just a pictogram for you. As we see, the blood comes to the right atrium, through the tricuspid again and again, through the right ventricle, and so on and so forth. So general overview, right? We look at general values such as cardiac output. We can estimate that with stroke volume, multiply by the heart rate. Generally, we're going to get a 4 to 8 liters per minute, or that's generally what is taught. Stroke volume is the amount of blood pumped in one contraction by either of the ventricles, depending on whatever it is that you're measuring. Stroke volume calculated by cardiac output divided by the heart rate times 1,000. That'll give you roughly 60 to 120 mLs per beat. And we should all be quite familiar with general blood pressures as they stand, diastolic 60 to 90, and then systolic 90 to 140. We're thinking about perfusion. So we've got all this blood flow, we've got our blood pressure, everything's working the way it should be. We can pretty much say that everything's working the way it should be and everything is getting what it needs organ-wise, looking at our map. So we're looking at our map, you want to think about perfusion. Guesstimate roughly 70 to 100 millimeters mercury. When I was working in CV ICU, it was 60 or above, right, for organ perfusion. We'll calculate that by taking our systolic plus our diastolic times 2, and we're going to divide that by 3 to get our mean pressures. Ejection fraction. Just think about this. If it's filled up to 100% and you eject 75%, right, that is the fraction that is ejected. 65, 75, and these values differ. I believe the general consensus is greater than 50 should have normal heart function, but we'll take this 65, 75%. And again, this is how much blood the left ventricle pumps out with each contraction. Again, you could likely measure it with the right ventricle as well, or any of the portions of the heart, any chamber of the heart. Pulse pressure, the difference between systolic and diastolic, normal is generally greater than 40. If it's less than 30, the pulse is likely going to be hard to find. So if you're an RT in the ER working one night, somebody comes in septic or severely dehydrated, something like that, you come in, you're like, guys, I can't feel radials or brachials or anything. You could say it another way and say, pulse pressure is less than 30, guys, can't get it. So we'll dive in just a little bit deeper when we're looking at our hemodynamics. We'll look at CVP or central venous pressure, pulmonary artery pressure, pulmonary capillary wedge pressure. These are big ones. And your mean pulmonary artery pressure is also significant as well. But our central venous pressure, if we can look through and see let's see if I can highlight it here for you. This will be our Swan-Ganz of sort, right? As it moves through the pictogram here, it is a Swan-Ganz. But our central venous pressure, roughly running 2 to 6 millimeters mercury, and we'll measure that with a CV line or a Swan-Ganz catheter. Pulmonary, if we have a Swan-Ganz catheter in, we can move that forward into the pulmonary artery, or we can then measure our systolic and diastolic pulmonary artery pressures. We can move it or inflate our cuff, and that will give us our pulmonary capillary wedge pressure, which we will see at the very top right of the pictogram here. One thing to note for pulmonary artery pressure, we are not going to have the cuff inflated. For pulmonary capillary wedge pressure, we will have the cuff inflated. So 2 to 6 for your central venous pressure, 25/8 roughly for your pulmonary artery pressure. I was taught when you're looking at your means, just think mean in the teens for your pulmonary artery pressure. And I always say like 13 to 19 generally gives you a pretty decent normal there. Pulmonary capillary wedge pressure, I've read literature that states that 4 and above is normal. I was taught 8 to 12, and I like to stick with 8 to 12. This is indicative of our left ventricular function, our pulmonary capillary wedge pressure is. And for those, we're going to need a Swan-Ganz catheter. So if we're looking at our monitors for a Swan-Ganz catheter, we can see the big differences between our atrial pressures here, right? Our ventricular pressures here, and our pulmonary artery pressure should be reflective of what the right ventricle is doing. So it's roughly about the same. You can see this level here, right? But just like when you're looking at an arc line or an arc line graph, we're going to have what would be, I guess you would call a dichrotic notch. Then we move over here to our left ventricular or a pulmonary capillary wedge pressures, which again are indicative of our left ventricular function and are a bit lower. Central venous pressure. So general measurement of the right heart function. Like we stated, our normal value is roughly 2 to 6 millimeters of mercury. When we're looking at our Swan-Ganz or our measuring device, we want to see that roughly in the right atria, close to receive that pressure behind that right ventricle. So our right ventricular pressures can be obtained. We can move that, especially if we have the Swan-Ganz catheter, we can move that further into the right ventricle and get a direct measurement there as well. Central venous pressure may be elevated with a number of hemodynamic abnormalities, as many certain situations cause hemodynamic failure and essentially a backup or right ventricular failure of sorts. High CVP, again, right ventricular failure, the right heart failure, cor pulmonale, and hypervolemia. These are going to be your two big indicators or objective findings when you're looking at high CVP, if you're looking at a monitor. And again, with the right heart failure, as the RT, you're going to have access to the patient's chart, so you'll be able to see, have they been diagnosed with right heart failure? If so, then that is to be expected. But the hypervolemia, especially with your cardiac patients and especially with your septic patients, fluid management is going to be highly important. So looking at high CVPs with hypervolemia, then you know that they may be fluid overload. We know what that may cause, or we'll find out later. A low CVP is essentially the opposite, right? So hypovolemia, hemorrhage, vasodilation, and we can know vasodilation as we see with our septic patients, as they may come or may manifest with massive vasodilation and decreased hemodynamic values or shock. I always found this graphic down here pretty neat. As we see atrial depolarization, we then begin to see our slope of our pressure gradients through the heart, right? So this is our EKG. This would be atrial waveform through a Swan-Ganz catheter. I always thought that was very neat, side by side. Pulmonary artery pressure. So, and I'm going to mix this up and say pulmonary airway pressure, but pulmonary artery pressure has a systolic and diastolic value, again, just like your arteries do, right? The mean value can be used for evaluation as well, like we talked about. The mean in the teens, it's 13 to 19, may indicate normality or normal hemodynamic values. So as I stated earlier with this, the balloon is not inflated. And again, we're measuring that pressure running through out of that, as we seen before, the right ventricle and pulmonary artery very close in pressure. We're seeing that pressure go through that pulmonary artery, right? And again, it has a systolic and diastolic, so we may have hypertension or hypotension of the pulmonary artery. So our normal value is going to grant us 20 to 30 systolic, 5 to 15 diastolic, and we can calculate that again and get our means. So with this, I bid the question at which portion of the body would yield the most valuable information when it comes to oxygen consumption. Well, we can look at the very distal end of the Swan-Ganz catheter. So we know that the pulmonary arteries are now moving straight from out of the heart to the lungs from the body, right? So this is the very last place the oxygenated blood can be measured, and will give you a more accurate representation of oxygen consumption and even cardiac function overall. So remember, push proximal, draw distal, and if we aspirate via the distal lumen, we know that this is the best way to obtain a mixed venous blood sample. Anything that will decrease blood flow through the heart generally will decrease pulmonary artery pressure. Again, we're looking at right heart failure, cor pulmonale, and hypovolemia. And again, if we just don't have the fluid to pass through, then of course it's going to be decreased. If we don't have the function to push it through, it's going to be decreased, right? Increases in pulmonary artery pressure will be seen with lung disorders or left heart complications. COPD is a big one. Pulmonary embolism, of course, we're looking at pulmonary embolism. There's actually a blockage within the pulmonary artery. And pulmonary hypertension, be it secondary or congenital, so on and so forth. And we know that COPD, we may have to stay or keep these patients in a hypoxic situation. And we could get into the biochemistry, but these COPD patients, again, may have increased pulmonary artery pressures. In the etiology, like we kind of said earlier, it could be idiopathic or congenital. We don't really know what would cause it. Drug-induced left heart failure, hypoxia, tumors, clotting, etc. So to fix this, we're going to treat the underlying factors, and we intubate if needed. If there's a blood clot, then we need to do something about the blood clot, right? We can't just treat pulmonary hypertension when there's a physical obstruction in the way. But generally what we're going to do, again, that was with a clot, they can get a clot, but what if it's not a clot? So generally we're going to use nitric oxide, Flolan or Velitri, I believe it's called, phosphodiesterase inhibitors, and aggressive fluid management with these patients. We know that nitric oxide works on the G proteins, and prostacyclin or PGE are going to help vasodilate. Now, I want you to remember also too that oxygen is a very potent vasodilator as well. So with these types of patients, these pulmonary artery hypertension patients, you'll see them on home oxygen flows of sometimes 10 liters or more, just to try to keep our pulmonary arteries from not looking like that and more looking like that. Pulmonary capillary wedge pressure. So this is, and I'll come up here and show you, this is where the balloon is inflated, right? So I want you to think about this. So everything that's being measured so far is coming through the heart. So the left ventricle is pushing everything out of the heart. So we inflate the balloon to mirror the function of the left ventricle. We don't want to inflate this for, I would say, no longer than 10 seconds, the balloon for pulmonary ischemia. But when we inflate the balloon, it blocks information from the right side of the heart and lets us know what's going on the left side of the heart. Again, it's like a mirror image. Normal value, you can use 4 if you want. I've read it in some of the literature. I use 8 to 12 myself, millimeters mercury. We'll see increased pulmonary capillary wedge pressure with left heart dysfunction and hypervolemia. Normal to decreased with nearly all other situations, as all other situations are an obstruction to ultimately the endpoint or the left ventricle. So congestive heart failure, we'll dive into a little bit of the path of this just a notch. So most common cause is coronary artery disease, hypertension, previous myocardial infarct, and really lifestyle, right? Every pretty much, I mean, besides genetic and so on, every single one of these are lifestyle influence, or heavily lifestyle influenced, right? So congestive heart failure is anything that may impede the outflow of blood to the body, right? So it's congestive heart failure. The heart is failing and starting to congest back up into the body. We'll see. So remember, the blood itself doesn't stop. If the pressure forward is greater than the pressure backwards, then the fluids then begin to back up, also following the path of least resistance as it does so, and eventually begins to flood the lungs. Many of us, or many congestive heart failure patients you'll see with pedal edema and so on, because they sit up in a chair, mostly because they have a hard time breathing when they lay down. You see them up in the chair, and once that blood starts to back up, we'll see it going into the peripheries of the body. We'll look at our little pictogram here. Normal, right? Decent amount of the muscles nice and toned, right? And then we look at heart failure. Look how big that left ventricle is. It's obstructing itself. It's like the COPD patient that becomes so bullous that their lungs won't inflate, so the obstruction becomes a restriction. And this is reducing oxygen-rich blood from coming through to the rest of the body. We'll have an enlarged heart or cardiomegaly in many cases. Again, the backup of fluid into the lungs and also that pedal edema. But how do we fix it? So congestive or pulmonary edema, which is what we're essentially treating here with our congestive heart failure patient, or could be treating. The treatment for that is oxygen if they're needing it. We know that oxygen, for one, decreases the workload of the heart, because the less oxygen we have, the more our heart rate goes up, the more we breathe, the more we work to try to get it in there. So we increase our oxygen intake to decrease the workload of the heart. We know that pulmonary edema and the like generally can be, or I won't say generally, but can be refractory. It can be refractory hypoxemia or manifest that way. And I was taught that at this situation, we bring in a CPAP or a non-invasive positive pressure ventilation or ventilatory machine. You're essentially trying to push all that fluid back out of the lungs, so it can start working the way that it was. The lungs were working the way they were before they become flooded. So CPAP or BiPAP if needed. A lot of these, there are overlapping conditions, of course, and CHF and COPD are like brother and sister in many cases. So they may need the pressure of the EPAP and the ventilation of the IPAP. And again, note that we use CPAP with spontaneously breathing patients. So BiPAP all the time is the go-to because you generally don't have to worry about it after that. Oh, are they spontaneously breathing? I don't know. They're triggering 99% of the time. So yeah. But we'll look at, again, fluid management with these patients. As a pulmonary navigator, one of the things that I asked my CHF patients is, have you gained any weight? Have you been urinating regularly, frequently, so on? Because we're going to watch the fluid management, because if the heart's not going to pump it effectively, then we can start to, I won't say neglect, but we start to really look at what we're putting in and saying, okay, well, if we put 2,000 in, we need to get close to 2,000 out, or wondering where it's at, right? Telltale sign of congestive heart failure patients is you go in, they've got 3 pillows and the bed is lifted to 90 degrees, right? You go and you say, oh my God, are you comfortable? Oh yeah, that's the only way I can sleep. So head of the bed is elevated for these patients, because they do get short of breath as they lay flat, and then portions of their lungs begin to fill with fluid. And of course, we're going to manage any other comorbidities, especially sleep apnea, diabetes, again, COPD as well. But really, how do we can keep putting Band-Aids on the pulmonary edema, but we really need to treat the heart itself, right? So we look at inotropes, beta blockers, vasoactives that are going to, 1, make the heart work more effectively, 2, make it easier for the blood to move through the body, or 3, do both, right? So what is it? ARDS, ARNIs, and so on. A lot of those drugs are going to be very targeted to the specific cardiac condition that's being observed. In this situation, we want to make, if our heart isn't functioning to 100%, we can give drugs to increase the contractility of the heart and so on. The correlation here, reduced left ventricular function that impedes or obstructs the normal flow of blood from the left ventricle to the rest of the body. CVP's normal or increased, right? That it can begin to start backing up into the blood, making the right heart starting to work harder. And generally, left heart failure, if left untreated, can lead to a right heart failure as well. Pulmonary capillary wedge pressure increased. Pulmonary artery pressure increased. That left ventricle is having to work harder to move that blood, and it's doing so less effectively. Cardiac output decreased. Indicative, right? Let's look at our normal ventricular chamber. Right, nice. Right, these are valves, semilunar valves. Easy thing to remember is your semilunars always leave the heart. Your cuspids always stay in the heart. But then look at this big, huge muscle right here, where that left ventricle has just been working so hard. And look how much smaller the left ventricular chamber is, right? So you could tell that this is just not going to function very well. You have reduced ejection fractions, you have reduced cardiac output, so on, so on. And as we stated before, if blood stops, we've got a much bigger problem. But if it's starting to stop, it's starting to slow, we can see that manifest. We need to do something about it. Right, because blood's going to keep going until it literally just closes right on up, right? So again, CVP, we'll just say normal for the sake of argument. Pulmonary capillary wedge pressure, pulmonary artery pressure, both increased through a Swan-Ganz, both increased. Cardiac output decreased, right? We know why now. ARDS. So acute respiratory distress syndrome, right? Most common cause of ARDS is sepsis, hands down. 33% of patients that aspirate will develop ARDS. A lot of them do also develop sepsis. Other causes of ARDS or ARDS, other causes are transfusion-related acute lung injury, pneumonia, trauma, or other infections, noxious inhalation of gases or fumes, anything that's really just going to acutely damage the lung, right? So generally, in a nutshell, when we're looking at ARDS, it's just massive pulmonary edema and atelectasis, just diffuse, right? 3 general stages: exudative, which is essentially kind of what we're seeing here, right? We're having all this extra exudate in here. Proliferative as it moves through, and then fibrotic as it begins to heal. So ARDS is, we can definitely tell right through here when we look at our interstitial space, how big that gap is compared to this one. Highly refractory to oxygen therapy, and generally does require more advanced therapies. When I say highly refractory to oxygen therapy, we go low flow, high flow, CPAP, and now we're starting to think other things, right? CPAP, BiPAP. So then we start to look at high, comfort flow, high flow, however, heated high flow nasal cannulas. But really, we want to treat the underlying cause. We can support with oxygen and mechanical ventilation and things like that. But if we're just throwing oxygen into the body, we're also damaging the AC membrane, we know. But we're also not addressing the problem. So I want to look at this bottom right picture down here, right? So this is one of the reasons. All right, so activated neutrophils, okay? These little bad boys right here, well, most of these are interleukins that attract other chemical mediators to cause inflammation and the like, with the release of histamines and heparins and all these other bad mamma jammas. Activated neutrophils release leukotrienes, platelet activating factors, other oxidants and proteases, which then begins, proteases break down proteins. And we know that there are a lot of proteins all throughout the alveolus, right? We're looking at tumor necrotic factors, alpha-1 interleukin 8, fibrin. I mean, this whole mess of just super damaging, overreactive molecules are just eating away at the lung. We look at our hyaline membrane here. Look how aggravated and mad it is. We have excess fibrin. We know that fibrin can cause fibrous tissues. Other proteases throughout the interstitial space, again, doing even more damage. Activated neutrophils, likely activating neutrophil elastase, which is a problem with our COPD-ish patients and our alpha-1 antitrypsin patients. We then start to get all of this blockage all throughout. We see here a platelet activating factor, and you got some platelets in here too. Swollen, leaky vessels blocking up the oxygen, swollen, leaky alveolus, not diffusing on the oxygen, other cellular debris, just junking up the lung, right? So we can see why this patient may be extremely refractory to oxygen therapy. And generally, we will see a lot of these patients on the ventilator. So sepsis in and of itself, which again, right, most common cause, sepsis in and of itself is an indication for hemodynamic monitoring, which when we're looking at hemodynamic monitoring with our CV patients or our med-surg or arduous patients, whatever, we're looking at very targeted therapy. So what is the correlation with hemodynamics and ARDS? So we look at our CVP, again, increased or normal. We just say normal for argument's sake again. Pulmonary capillary wedge pressure is normal. Pulmonary artery pressure is increased. And when we're looking at our cardiac output as a whole, I want you to make sure and look at sepsis as a whole, right? So different portions of sepsis, they may be hypertensive for a short amount of time and then markedly hypotensive. So the cardiac output can vary depending on the severity of as we're looking at sepsis. So how does the pulmonary hypertension occur in ARDS, right? So it's almost kind of the same mechanism when you're looking at pulmonary edema, congestive heart failure, and things like that, but specific to ARDS, we're looking at vessel obliteration, right? So if we go back to our picture here, vessel obliteration, right? All of this is just eating up our alveolar capillaries. Pulmonary vasoconstriction, again, as all those particulates move through the blood and start to aggravate the vessels, pulmonary vasoconstriction can occur, specifically as we're looking at with arduous patients at marked hypoxemia or hypoxia. Microthrombosis, again, we look back at our picture here and we have all of these extra platelets, we have all this extra fibrin, we have all these extra busted up broken protein pieces, already blocked up, nasty little vessels. So of course we're going to have microthrombus literally all throughout the lung, which again, as we know, is going to cause a shunt factor to increase and become even more hypoxic outside of the junk that's inside of the lungs, right? We're looking at hypercapnia. As these patients get sicker and sicker, they start working harder and harder and harder. They become hypoxic or hypercapnic, which is again leading to pulmonary hypertensions. Vasoactive mediator imbalances. Again, we look back at the vasoactive mediators. Platelet activating factors, leukotriene to a small extent, migrating neutrophils, and again, probably most likely neutrophil elastase, and it's releasing factors. And again, you're going to have eosinophils and all sorts of other goodies in there, releasing things like histamine and heparin, which we're looking at heparin as a blood thinner and histamine as a vasodilator, again, on top of the sepsis. So, and other biochemical cascades, as I was alluding to. treatments for this, we're going to treat the underlying condition. So somebody comes in with septicemia, you're going to look at aggressive fluid management, right? IV arm fluid management. But then you're going to look at what is causing this situation. Most of the time we'll look at bacterial situations. Viral can turn into bacterial, as we know. But we're going to look at broad spectrum antibiotics just to cover the scope before we can start to culture and grow and look and pull blood and all this stuff. Broad spectrum antibiotics, such as like cefepime or Maxef or whatever it is. And then once we get our gram stains and all that stuff back, we'll look at targeted antibiotic therapy or what it may be. And then we're going to treat that cause, right? Whatever's causing the diffuse and marked hypoxemia, we're going to try to reverse that. And once doing so, we'll correct our hemodynamic values, because if we don't have an arduous situation, we don't have all of this, right? Theoretically, yes. So how are we going to treat them? We're going to treat them with oxygen, right? That's more than likely what you're going to do as soon as they roll through the ER or the, direct admit, whatever. What if we can't oxygenate them, ventilate them, right? What if the antibiotics aren't working fast enough? What is the wrong type of antibiotic? So on and so forth. Well, we're going to likely intubate them, place them on a mechanical ventilator where we can do all the work for them essentially for a little bit. And all that entails from VC plus to APRV to wean them on PAP, whatever you got to do, they're going on mechanical ventilation. Again, fluid management, especially as we're looking at fluid management as an acute septic situation, but also because we know it's messing with our hemodynamic values, right? ECMO in some cases, depending on the situation, looking at PF ratios generally less than 100, we'll start to consider ECMO. Oxygen index greater than, I believe it's 40, we'll start looking at ECMO. So that may be the case. And a lot of the times with this type of ECMO, and y'all can correct me if I'm wrong, you're looking at a decently functioning heart in the instance of sepsis. So we'll use VV ECMO to support the lungs as the heart does or manages all of our pressures. We'll look at prophylactic or therapeutic anticoagulants, as we've seen in the pictogram, and as we heard here. Of course, we have these microthrombi. So we'll go ahead and do prophylactic anticoagulant therapy to try and prevent that or fix it as it is there. Inhaled nitric oxide, specifically for very high pulmonary artery pressure. Because if the pulmonary artery pressure gets too high, then none of that blood's just going to dribble into the lungs, and it's not going to flood into the, I won't say flood, but move through the lungs as it should, right? Tons of studies come out for proning these patients, moving those dependent lung areas, and moving that blood around to the parts of the lung that's doing the work. And secondarily, and especially when I worked in LTAC, moving these patients around, you go into suction a patient or so, and you don't get nothing. PT, OT, somebody goes in there, you flip them and prone them, and the next thing you know, you're just getting gobs of stuff out. So proning definitely as a physiological and somewhat of a mechanical benefit to the patient a lot of the time. Even during COVID, we were asking patients to prone on 5 liters or more. We'd ask them to prone, and they did pretty well with that. So the difference, right? What exactly is the difference, and what does it mean? Like, what is it representative of? When looking at hemodynamic portions of these two diseases, it becomes very apparent how to differentiate between them. If you haven't caught on, we're going to break it down even further. Of course, these two diseases present with other obvious findings. Y'all, we're looking at one snippet of the picture, right? You more than likely, as if you're a practicing clinician or an academist, whatever, you're likely going to know more about the patient than just hemodynamics, right? Oh yeah, they only urinated 200 mLs in the past 3 days. They haven't taken their Lasix. You're like, okay, I get it. You don't have to look at hemodynamics values for this, but it's decent to know how this is impacting and how it will result if not handled appropriately. So congestive heart failure, right? CV or versus ARDS or CVP, the same, right? For this measure, just this measure right here, between CHF and ARDS cardiac output, would just say slightly decreased, right, for both. But look at our pulmonary artery pressure and our pulmonary capillary wedge pressure. Just look at that for a second. So we'll look at this. And you'll say, well, what in the world? Why would that be happening, right? Why would the CHF, the whole thing's messed up, but with ARDS, it's not. If one thing's messed up, the other should be right. Well, no, not exactly. And we'll see kind of, oops, sorry. The pulmonary capillary wedge pressure, what is that indicative of? Right? That's what you got to look at. Is pulmonary capillary wedge pressure indicative of the lung or the movement through the lungs, or what? It's the left ventricular function, right? And we learned that in congestive heart failure that our left ventricular function is decreased, causing an increase in our pulmonary capillary wedge pressure. This is a measure of the left ventricle, where pulmonary artery pressure is not, right? But with ARDS, because we have so many other things going on with the lungs themselves, it don't have nothing to do with the left ventricle, right? It's nothing to do with the left ventricle. It's completely normal. But then we look at all those other functions that we just looked at that may cause an increase in pulmonary artery pressure, and you may be able to differentiate the two. Got a small little case report here, nothing crazy. So a patient has been mechanically ventilated for 8 days post-CABG, right? It's a cardiac patient. Multiple weaning tips have failed, and the patient has required continuous sedation. We know that's going to prolong our vent days, and if we're needing prolonged vent days and continuous sedation, maybe the patient is not working with the ventilator very well, causing shearing damage, pressure damage, barotraumas. Recent labs have indicated the need for prophylactic sepsis workup. Cardiac surgery isn't a pretty thing, right? Well, to some nerds, it's a very pretty thing, but generally it's not a very pretty thing. It's pretty dirty. Very high chance of or risks of infection. So recent labs have indicated the need for prophylactic sepsis workup. The patient has required vasopressors and fluids on a number of occasions, right? So we're looking at fluid management, pressure management, and they might have sepsis, right? Again, y'all, we have a plethora of other things to look at to determine. We don't need a white cell count exactly to look at sepsis. We can look at procalcitonin or whatever. And so for all this, they just said, you know what, let's just put a Swan-Ganz in, right? Let's just go ahead and pop that sucker in. So they put it in, and you start rounding, and these are the pressures you get. We get a normal CVP, pulmonary artery pressures, 31/19. You can calculate the mean on that about 25-ish. Pulmonary capillary wedge pressure is running about 11. Cardiac output's 4.7, gives us rough cardiac index, which is roughly half of your cardiac output of 2.3. Blood pressure through the arc line, and we'll, for the sake of it, we just say the arc line is properly placed and the transducers properly placed and all that good stuff. So we get an accurate blood pressure of 137/86. Our PVO2 is 24 millimeters mercury. Now, you know what we mean. You know what I mean when I say we have a PVO2, right? We've drawn distal. Pulmonary vascular resistance running you 200, 400-ish, give or take, depending on your measurements. And SVR is going to run you about 14 to 1600-ish as well. After reviewing the monitor, the physician asked for thoughts and recommendations. So what do you think the underlying problem is, really? So this, what is this? That's normal, right? Our pulmonary artery pressure is not normal, right? We'll call that super increased. And we'll star that because that's going to be super increased too, right? Pulmonary capillary wedge pressure, it's definitely not 4, but it's normal. Cardiac output, cardiac index, we'll put a check by that. Yeah, that's good. All this is good. All this is decent, right? Well, this isn't super great, but so what do you think the underlying problem is? Well, if we go back and we look at our thing here, our little representation, so increase, 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 normal. So increase, increase, normal. So I'd have to say it's ARDS, right? And how would I have come to that conclusion? Well, it was pretty good set on the description here, but I'm looking at my pulmonary capillary wedge pressure versus my PAP, right? How would I approach fixing this? Well, we need to get some antibiotics. We need to fix the underlying problem, right? Because if not, all of these things are just going to keep getting worse. Recap, we went over the flow of blood. We looked at our hemodynamic normals and treatments for abnormals. We looked at CHF and its hemodynamics. We looked at ARDS and its hemodynamics, and we looked at the difference between the two. There are my references. Y'all, I really appreciate you. Hit me with any questions you got. I'll answer them the best I can. I'll hand it over to Keith.